with a specific clinical observation, intermenstrual spotting that occurs precisely between regular menstrual periods. This diagram shows a standard 28-day menstrual cycle, with bleeding tracked strictly between days 14 and 16. Cycle lengths naturally vary. If a cycle compresses to 25 days or stretches to 35, this bleeding window shifts in exact proportion. Clinically, visible macroscopic spotting during this exact window is observed in only about 5% of cycles. This breakdown compares clinical observations against cellular data. When we analyze cervical mucus under a microscope, we detect red blood cells in roughly 60% of all regular cycles. Intermenstrual spotting is a statistically dominant underlying feature of human reproductive physiology. The reproductive system continuously builds the endometrium to prepare for potential implantation, yet exactly halfway through its cycle, it actively induces a shedding event. It is easy to assume a single biological trigger initiates this shedding. In reality, the single symptom of mid-cycle spotting is the result of two completely distinct, parallel mechanisms operating simultaneously. The first mechanism relies on a systemic, transient drop in circulating hormones. This split schematic maps the two pathways. On the left, we track an endocrine withdrawal loop. On the right, we examine a localized, gross anatomical rupture at the ovary. Understanding the clinical symptom requires deconstructing both the invisible hormonal data and the physical fluid dynamics of the reproductive tract. The first pathway begins as a maturing ovarian follicle actively secretes estrogen. This chart maps estrogen levels against the uterine lining. As the follicle grows, estrogen levels steadily rise, and the endometrium thickens in direct response. At the precise moment of ovulation, the mature follicle physically bursts to release its egg. With the follicle ruptured, its hormone production suddenly stops. The estrogen curve drops precipitously mid-cycle. The uterine lining immediately loses the chemical support required to maintain its thickness. Deprived of estrogen, localized microulcerations form across the superficial layers of the endometrium, shedding small amounts of tissue and blood. This structural destabilization establishes the first primary origin point for mid-cycle spotting. The system responds with a biological rescue mechanism. The collapsed remains of the follicle reorganize into a new temporary gland, the corpus luteum. It takes 7 to 8 days post-ovulation for this newly formed gland to reach structural maturity. On the chart, it generates a massive second surge in estrogen and progesterone. This surge rapidly seals the microulcerations, halting bleeding and prompting the endometrium to thicken. The resulting blood loss is simply an operational lag time, a brief period of vulnerability between the collapse of the follicle and the activation of the corpus luteum. The second pathway bypasses the uterus entirely, originating in the gross anatomy of the ovary. Ovulation is a physically destructive, mechanical event. The ejection of the egg forcefully tears the outer wall of the ovary, rupturing the microscopic capillaries distributed across its surface. The abdominal cavity reabsorbs the vast majority of this resulting minor hemorrhage, but a critical fraction escapes into the surrounding space. The finger-like projections at the end of the fallopian tube, the fimbriae, operate under a strict biological mandate to capture the released egg. Through an active sweeping motion, the fimbriae draw the egg inward, pulling the escaped capillary blood and follicular fluid directly into the fallopian tube. The fallopian tube utilizes continuous muscular contractions, known as peristalsis, to transport this fluid. This diagram maps the continuous anatomical route. The peristaltic waves push the stray blood down the fallopian tube, depositing it directly into the uterine cavity. This physical pipeline continuously channels the ovarian fluid down through the cervix, producing visible mid-cycle spotting. The symptom we observe is the physical exhaust of a violent anatomical extraction, working in parallel with the chemical withdrawal. Physicians use the precise mechanics of these pathways to separate normal ovulatory function from dangerous pathological states. Because both the endocrine crash and the mechanical tear are strictly self-limiting, their clinical signature is highly predictable. This matrix defines the diagnostic parameters. First, the total volume of mid-cycle spotting must remain strictly lower than a normal menstrual flow. Second, the spotting has a specific temporal duration. It resolves between 2 hours and 3 days, and absolutely never exceeds 7 days. If an individual consistently exceeds these volumetric or temporal limits for over 6 consecutive months, the condition breaches normal physiological function. When the bleeding strictly adheres to these limits, it operates as a highly accurate biological marker. Tracking this specific spotting provides exact, real-time confirmation that a follicle has ruptured, mapping the optimal fertility window for conception. Tightly confined to its physiological boundaries, this symptom acts as a precise, built-in diagnostic tool confirming a healthy reproductive engine. When a patient's symptoms cross over into the pathological side of the matrix, physicians evaluate 2 distinct categories of failure. The first category is unctional failure. This involves severe dysregulation of the central hormonal control loop, triggered by external pressures like extreme stress, chronic fatigue, or severe immune suppression. The second distinct category is organic pathology. Organic pathology indicates tangible, permanent structural damage directly to the reproductive organs, presenting as growths like cervical polyps or submucosal fibroids. By rigorously quantifying a macroscopic clinical observation, like intermenstrual spotting, physicians diagnose the deepest microscopic and structural health of the human endocrine system.